Hi, I'm Ina Lobeck, and I'm a pediatric and fetal surgeon.
Hi, I'm Nithin Sajenkila. I'm a general surgery resident.
And we'll be talking about ex utero intrapartum treatment. Exit is a complex delivery option for babies who may die at birth due to airway obstruction or hemodynamic instability. Multiple types of exit procedures are described in the literature that differ based on fetal indication as well as specific clinical goals. These include the most common exit to airway, exit to resection, exit to ECMO, and the newest exit to ventricular pacing. With each of these categories, it's important to consider the prenatal diagnosis as well as the diagnostic index of severity in relation to risk stratification and indications for the procedure. We'll begin with discussion of the most common and least controversial type of exit, which is exit to airway. A 2020 consensus statement by the International Pediatric Otolaryngology Group recommended delivery modification for patients with prenatally diagnosed micronathia, fetal head and neck masses, and chaos. Although this Delphi only considered opinions from ENTs, this laid the groundwork for further investigation into exit indications. The North American Fetal Therapy Network is an organization of 54 fetal centers around the world who collaborate on research initiatives. Similarly to the IPOG recommendations, a 2023 survey of NAFNet sites showed that most institutions would consider exit consultation for patients with head and neck masses, chaos, and micronathia. But most would also consider exit consultation for tracheal occlusion balloon removal, as well as thoracic and mediastinal masses. The survey also showed that most institutions have only performed 1 to 5 exits in a 10-year period, and most were for micronathia and head and neck masses. Due to the rarity of these conditions, a prospective cohort study is currently being conducted by NAFNet. Moving on to the diagnostic criteria, mandibular anomalies range in spectrum for typically less severe retronathia to micronathia and the extremely severe anathia, otocephaly, synsotia dysnathia complex. The key metrics for evaluation of prenatal micronathia include a jaw index less than the 5th percentile and inferior facial angle of less than 49.2 degrees. Other metrics include gestational age-adjusted mandibular length, mandible width to maxilla width ratio, and frontonasomedial angle. Moving on to fetal head neck masses, these are a wide spectrum of anomalies, including but not limited to cervical teratoma, cervical facial lymphatic malformations, fetal goiter, thymic masses and cysts, and brachial cleft cysts. Prior to prenatal detection, the survivability of fetal head and neck masses was reported to be as low as 0 to 20%. Outcomes have improved substantially, however, with prenatal detection and the option for delivery modifications such as exit procedures. While cervical teratomas account for only 2 to 6% of all teratomas, they may result in airway compression, obstruction, and distortion due to mass effect, resulting in significant morbidity and mortality at birth, which is why 98% of NAFNet centers would consider head and neck mass an indication for exit. Multiple metrics have been proposed to differentiate fetuses at high risk of airway obstruction at birth by examination of a heterogeneous group of diagnoses. These include the tracheoesophageal displacement index of 12 millimeters or greater, polyhydramnios, solid mass characteristics, stage 2 or 3 lymphatic malformation, neck extension, compression of neck vessels, size greater than 5 centimeters, and floor of mouth involvement. Finally, chaos is a rare syndrome that most commonly results from laryngeal atresia, but can also be caused by tracheal atresia or stenosis, subglottic stenosis, obstructing webs, or cysts. As gestation advances, trapped distal lung secretions will lead to lung expansion and hyperplasia. Ultrasound findings thus will include large echogenic lungs, a flattened or even inverted diaphragm, airway dilation below the level of the obstruction, compressed mediastinal structures, and polyhydramnios secondary to esophageal compression. The increased mediastinal pressure can impair venous return, leading to cardiac dysfunction, fetal hydrops, and subsequent fetal demise. Unless there's a spontaneous decompressive airway opening or fetal intervention to open the airway, Chaos is uniformly fatal without exit to airway performance, and thus chaos is a uniformly accepted indication for exit. In exit to airway establishment typically proceeds from the least invasive strategy to the most invasive as needed, though adaptive decision making is critical in these situations. While multiple algorithms exist, the core techniques of airway establishment include video or operative laryngoscopy, Seldinger assisted video telescopic intubation, rigid ventilating bronchoscopy, transnasal fiber optic intubation, retrograde intubation, and tracheostomy. For airway obstruction caused by extrinsic compression from neck or thoracic masses or cysts, resection or decompression of the obstructing lesion may be necessary to establish an airway. In cases where time is limited due to placental separation, mediastinal airway access or ECMO may be considered to bridge the patient to airway access.
Exit to resection has been described for thoracic and mediastinal masses, as well as for select cases of sacrococcygeal teratoma. A Delphi study from the North American Fetal Therapy Network would recommend exit to resection for teratoma and lymphatic malformation, as well as for select cases of congenital lung malformation and pericardial masses. However, less consensus was established to determine what diagnostic indices of severity should be considered for these indications. Exit to resection for thoracic masses includes general anesthesia with complete uterine relaxation and partial delivery of the fetus as for other exit procedures. This is followed by thoracotomy with mass resection or lobectomy while on placental bypass. Recently, the section to resection technique has also been considered, eliminating the need for maternal general anesthesia, uterine hypotonia. In these cases, a standard cesarean delivery is performed with mass resection performed in an adjacent operating room. Alternatively, modified section to resection techniques have also been performed whereby intubation and thoracotomy are performed on placental support, but completion lobectomy is performed in an adjacent OR with delivery. A 2023 single-center review found that among patients with a pathologic diagnosis of CPAM, there was no difference in postnatal survival, nitric oxide use, NICU length of stay, ventilator days, use of ECMO or ECMO days between open fetal surgery, exit, and section to resection patients. However, patients undergoing exit had a higher incidence of early hydrops compared to section to resection, had a higher initial and final CVRs, and were initially assessed later in gestation, showing that for the most severe cases, exit should be considered. Moving on to exit to ECMO. This is a highly controversial delivery strategy and a far less common indication for exit, given established postnatal resuscitation guidelines for CDH and congenital heart disease, which have resulted in satisfactory outcomes. The thought behind exit to ECMO for severe CDH includes avoiding harsh ventilation during initial resuscitation and ECMO cannulation. However, studies have shown that there is no statistically significant difference in pulmonary, nutritional, cardiac, and neurodevelopmental morbidities of survivors who undergo exit to ECMO versus those who had standard delivery and resuscitation. Likewise, most NAFNet centers would not consider exit to ECMO for CDH. Placental support varies depending on the technique of delivery. While cesarean section only offers 1 to 2 minutes of support, an operation on placental support or mild uterine relaxation with an awake mother can offer support of 5 to 20 minutes. A standard exit includes general anesthesia with complete uterine relaxation and may offer an average of 45 minutes of placental support, though cases of support for up to 150 minutes have been reported. Technical goals of exit include minimizing maternal blood loss, maintaining a greater than 5 centimeter distance from the placenta, and delivering only essential fetal body parts to maintain uteroplacental support. The uterine stapler with absorbable staples has been widely used to optimize the exit technique. Risks of exit include risks of a traditional cesarean section, in addition to maternal anesthesia risks, increased procedure time, bleeding, risks for break in sterile field, and inability to bond with the child immediately. Exit may be a beneficial delivery modification option for patients who have high risk of cardiorespiratory or airway compromise at birth. While institutions generally agree on the conditions which may warrant an exit, due to the low volume of exit candidates, the diagnostic indices of severity for conditions warranting exit are yet to be described. Exit involves multidisciplinary collaboration and should only be performed at centers with this expertise. Exit presents risks to both the mother and fetus, thus, fetal beneficence and maternal non-maleficence must be considered.